Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. We'll be reviewing soft tissue tumors exhibiting neural, lipomatous, and myoid differentiation. So let's start with lesions of neural tissue by reviewing the appearance of normal nerve fibers in the skin. We're about as far away as we can get from the central brain and spinal cord out here in the outer lands, if you will, of the distal peripheral nervous system. But these peripheral nerves have very distinctive and fairly complicated features, and the many different neural tumors that we'll look at do reflect the different histomorphologic and immunophenotypic characteristics of these different structures. So when people think about a nerve, they're mostly thinking about the central portion, so like the nerve with the axon, the neuron, which is not really a proliferative cell, but it's associated with the Schwann cell, which can potentially proliferate. So when we see these peripheral nerves cut in cross-section, they have spindle nuclei and kind of a delicate eosinophilic fibrillary appearance. And we know that we can't and we don't really need to distinguish between neurons and Schwann cells at the H&E level. There is a surrounding tubular fibrous sheath known as the perineurium, and then in many nerve fibers you'll see an intervening kind of myxoid zone of connective tissue known as the endoneurium. At higher magnification and sectioned a bit more longitudinally, we can see the central portion composed of neurons and Schwann cells. We can see that myxoid or mucinous stroma of the endoneurium and then surrounding perineurium. And the endoneurium does contain many structures. There's capillaries, mast cells, fibroblasts, but I don't usually see those. I just rely on that myxoid appearance to identify a mature, fully differentiated nerve fiber. In a minority of sections of nerve fibers, you'll see a unique appearance that is kind of cool. It's kind of cross-like or cruciate, and this represents what is known as the perinodal junction or perinodal space around nodes of Ranvier. Remember those nodes of Ranvier from medical school, which represents a gap in the myelin sheath in between adjacent Schwann cells. When the myelin sheath ends, it forms cytoplasmic loops that create this cruciform appearance. The vast majority of neural tumors can be diagnosed on H&E. Special stains are not required, but this is a relatively comprehensive list of stains that can be critical for establishing or confirming a histologic impression. Probably S100 protein here is the only one that I order on at least a monthly basis, though. There are specialized nerve endings that can be identified on H&E. Near the epidermal surface, Meissner's corpuscle has a sensory function, but its appearances are frequently recapitulated in neurotized intradermal melanocytic nevi. In the deep dermis, the Pacinian corpuscle resembles an onion skin and has more of a pressure function. I think most or all of you probably have seen or heard Dr. Jared Gardner. If you take the intersection of dermpath, bone and soft tissue path, and social media, he is pretty much the world's supreme leader. And despite the fact that he is younger than me, he's still become a role model for me in many ways. I remember several years ago, he personally set up my Twitter and Instagram accounts. He just grabbed my phone and said, "Max, it's so easy. I'll do it for you." So Jared, at the dreaded risk of overstepping my bounds, I hope you don't mind that I'm using this most beautiful image of a Meissner's corpuscle that I found on the internet. I'm planning to cover the following entities in varying degrees of detail. To keep it in perspective, a more comprehensive list and classification of neural tumors would look more like this. So the ones that I'm covering are the ones highlighted in gray. And this is from the excellent Cutaneous Soft Tissue Tumor book by Luis Requena and Heinz Kutzner. No conflicts of interest, just great colleagues. So here we go. Am I starting in order of the classification, or am I starting with most common tumors first? Experienced observers may wish to pause and diagnose. If you like a clinical history, this is a congenital plaque of alopecia on the occipital or parietal scalp. Meningothelial hamartoma is indeed rare, and the clinical presentation is quite distinct and stereotypic. A congenital plaque of alopecia. And so we can see at scanning magnification here that the hair follicles are largely displaced by an infiltrate of cells that at high magnification would be cytologically bland mononuclear cells with eosinophilic cytoplasm. The distinctive immunostain is epithelial membrane antigen, or EMA, and this makes sense because EMA is also positive in perineurioma and cutaneous meningioma, and the perineurium is in fact kind of the distal peripheral extension of one of the meninges, the arachnoid mater. Bland mononuclear cells with eosinophilic cytoplasm exhibiting a diffuse and vaguely whorled pattern of growth. EMA positive. Sometimes the meningeal cells will form more discrete whorled aggregates resembling sarcoidal granulomas, and calcified bodies, psammoma bodies, may form. These same characteristics are diagnostic of cutaneous meningioma when occurring at other sites and other clinical settings. In many cases, cutaneous meningioma is not really a neoplasm. It's more like a malformation or a heterotopic deposition of meningeal tissue. But at the same time, I don't think I needed to publish this case report of intracranial malignant meningioma eroding through the frontal bone of the skull to remember that for every benign category, there is a malignant counterpart. Boy, am I glad this patient no-showed for my lump and bump clinic when I was a first-year dermatology resident. Going from the very rare to the very common, neurofibroma is probably the most commonly encountered neural tissue neoplasm. They often are superficial, kind of polypoid papules, and microscopically there is a discrete, circumscribed, but non-encapsulated proliferation of small spindle cells. These are mostly Schwann cells, but there can be some axons or neurons admixed. The stroma tends to have thin or delicate collagen and is often slightly mixoid. To the untrained eye, it can be a little bit subtle, but there is an infiltrate of spindle cells in the central portion associated with slightly thin collagen fibers. More or less here, but of course not this perfectly well demarcated. Typically, there's a very superficial zone of sparing in the papillary dermis. And some of the slightly exaggerated spaces between thin collagen fibers within the tumor is likely attributable to interstitial mucin. The spindle nuclei in neurofibroma are typically small and sometimes wavy or S-shaped with tapered ends. Scattered mast cells are also typical. This is exactly the type of pale staining that you definitely don't want to see on an exam, but this is from my old resident collection where I was diligently pairing actual clinical photos with photomicrographs, and I think the dome-shaped profile and the distribution of cellularity is still characteristic of neurofibroma. At higher magnification within the same lesion, we can again see scattered mast cells and the typical profile of the spindle cells, wavy and S-shaped with tapered ends, kind of like the nematode, C. elegans. Intradermal melanocytic nevi often undergo a degenerative phenomenon known as neurotization, sometimes resembling neurofibroma. However, in my experience, more often the neurotization in intradermal nevus resembles Meissner corpuscles. These are typically most prominent in the deep dermal portion of the nevus. If you carefully examine the superficial-most portion of the lesion in the papillary dermis, typically you will identify some classic melanocytic nests and maybe even a subtle junctional nevus component. With multiple neurofibromas or even a single plexiform neurofibroma, we should be thinking NF1. The commonly encountered conventional small neurofibromas have no distinctive histologic features, whether they be sporadic or NF1 associated. However, some other patterns are unique. The diffuse neurofibroma and plexiform neurofibroma have distinctive appearances. In contrast to the commonly encountered polypoid and buttonhole papules of common neurofibromas, diffuse neurofibroma presents as a plaque and can resemble dermatofibrosarcoma protuberans in its extensive infiltration and entrapment of subcutaneous fat cells, with essentially the same cytologic features at high magnification. Plexiform neurofibroma is regarded as pathognomonic for NF1 and is characterized by multiple large nodules resembling large nerve trunks, very well demarcated. Centrally, there are Schwann cells and variable numbers of axons demarcated by a perineural sheath, and taken together forming a plexiform pattern of growth that resembles a bag of worms upon gross examination. The malignant counterpart of neurofibroma, malignant peripheral nerve sheath tumor, MPNST, disproportionately affects patients with NF1. We expect to see atypia and increased mitotic activity. As a rule, MPNST does not arise primarily within the skin, but more likely from underlying soft tissue. The main differential diagnosis for MPNST in dermatopathology is spindle cell or desmoplastic melanoma. So we can use the fact that at least half of MPNSTs will arise in patients with a history of NF1 to kind of guide our prior probability. In addition, S100 is usually diffusely and strongly positive in desmoplastic spindle cell melanomas, whereas S100 is often absent, weak, or focal in MPNST. And another immunostain that can be used is H3K27 ME3, which is trimethylated H3K27, or a loss of trimethylation on lysine 27 on histone 3. I can never remember that. But if simply remembering the name wasn't complicated enough, a subsequent study showed or suggested that loss of dimethylated rather than loss of trimethylated H3K27 might be a more specific diagnostic marker for MPNST. Subsequently, the study cited here looked at both in comparison with a wide variety of tumors, both melanocytic and neural tumors and beyond, and found that there does seem to be limited diagnostic specificity for both of these markers. And I think that, speaking for our own lab at least, I feel like most laboratories do not have these markers at the ready. So I think in practice, with these tumors being rare enough, I'm still going to be focusing and relying on the clinical setting and hopefully that characteristic loss of the strong S100 or SOX10 staining that I would expect in melanocytic tumors, but is more characteristic in MPNST, with the exception of the epithelioid variant of MPNST. Now, my sense is that most laboratories in the United States do have PRAME, preferentially expressed antigen in melanoma, which we now know is not only diagnostically useful in nevus versus melanoma, but also in other areas, including MPNST as an ancillary diagnostic marker. Returning now to the world of common neural tumors, Palisaded encapsulated neuroma, or PEN, is the first of a group of really unrelated entities that are classified as neuroma, although some of them actually represent hyperplasias. PEN, however, is regarded as a benign neoplasm, and in contrast to neurofibroma, they tend to be very well circumscribed, although not necessarily encapsulated. Sometimes in the superficial portion of a PEN, it may be more poorly circumscribed, resembling a neurofibroma, especially if you have a partial sampling, but a complete inspection of the tumor profile will reveal very sharp circumscription, at least in the inferior portion of the tumor. In contrast to neurofibroma, in PEN, the spindle cells are aggregated in more discrete and compact fascicles, identifiable not only by the spindle cells themselves, but the empty clefts surrounding them. PEN stereotypically occurs as a solitary small superficial papule on the face. Any other clinical setting, you probably should seriously consider a differential diagnosis of Schwannoma. Again, we see discrete compact fascicles close to the epidermal surface. Despite the original name, palisaded arrangements of spindle cells are typically not present or prominent in PEN. It's the Schwannoma that is the palisading champion. So I don't need to verify if you're human, but I do need to verify if you are awake. Please pause and select. Easy, right? You just had to be awake 10 seconds ago. Piece of cake. Okay, one more. So here we see that exaggerated space surrounding the central portion of the nerve fiber with a a subtle hint of some mucin. So this is consistent with a mature nerve fiber, which is typically seen in which type of neuroma? It's the traumatic or amputation neuroma. This includes accessory digit and perhaps slightly more controversially, epithelial sheath neuroma. Traumatic neuroma typically occurs at sites of trauma, classically the finger, so a biopsy from acral skin is classic, and one sees a proliferation of fully differentiated or mature nerve fibers, classically associated with scar. In this case, the scar is present in the upper dermis. And in the deep portion, mature, fully differentiated nerve fibers. So in one sense, traumatic neuroma really is more like a hyperplasia. It's a proliferation of normal appearing structures in response to a known trigger. However, from a clinical point of view, it can behave more like a benign tumor in that the lesions do not clinically regress. Accessory or supernumerary digit can be readily viewed as a variant of traumatic neuroma, as in utero autoamputation of the supernumerary digit. The clinical setting is quite stereotypic, congenital lesions located only on the lateral ulnar base of the pinky. The fully differentiated nerve fibers are identical to those in any traumatic neuroma, although you would not expect to see a scar. Epithelial sheath neuroma is a curious and distinctive entity that by definition occurs in the absence of a history of known trauma, although it's been increasingly suspected that this might represent something along the lines of a traumatic neuroma in response to subtle or subclinical trauma. This is an acquired solitary lesion, classically on the upper back. Microscopically, we see a superficial increase in the number of nerve fibers, which are large and variably surrounded by epithelium. The perineural epithelial aggregates in epithelial sheath neuroma are cytologically bland and derived from skin adnexal epithelium. So, what do you say? Another example of epithelial sheath neuroma? No, these cells are a bit more basaloid, and this is perineural invasion associated with basal cell carcinoma. And so we have a very clinically relevant differential diagnosis for the presence of perineural epithelium that is of particular relevance to pathologists as well as budding Mohs surgeons. Interpretations of these cases become even more complicated in the context of a re-excision specimen. So this is a complicated topic. I can't fully present it now, so I'm kind of going to leave you hanging. But here are a few references that will get you up to speed if you're interested. And suffice it to say that each case will require a careful composite assessment of all the clinical pathologic features in the case in the context of what is known about the primary tumor, as well as epithelial sheath neuroma and other entities such as re-excision perineural invasion, reactive neuroepithelial aggregates, and reparative perineural hyperplasia. And lastly, Morton's neuroma deserves to be in quotes because it's not a true neural tumor. I used to see a lot of these in Connecticut when we were reading for podiatrists, but I never see them nowadays. But stereotypically, these occur between the third and fourth toe, and what one sees microscopically is just degenerative changes. So you can see hyalinized vessel walls, fibrosis, myxoid stroma. There may be edematous nerves, but it's just degenerative changes that in other histologic contexts might be characterized as ancient or even symplastic. Nonspecific degenerative changes. Morton's neuroma is not a neural neoplasm. In contrast, the Schwannoma is about as bona fide and de rigueur as you can get for a neural tumor. Similar to the PEN, these are very well circumscribed tumors, but in contrast, these arise in the subcutis and are both larger and deeper than a palisaded encapsulated neuroma. Antony A is the more distinctive of the two morphologic patterns seen in Schwannoma, characterized by the verrucae body formed by the space between palisaded arrangements of the spindle cells. Antony B tissue is a bit more nondescript, characterized by bland spindle cells and associated myxoid stroma, often more prominent around the periphery of the tumor nodule. Higher magnification shows the distinctive palisaded arrangement of the spindle cells in Antony A, the Verricae body being the space between them. And they usually seem to be quite sociable, usually hanging out in groups, even sometimes sharing the same palisade. Now, the ancient or degenerative changes that were so mundane in the Morton's neuroma can contribute to a significant amount of diagnostic challenge when superimposed on a Schwannoma, so-called ancient or degenerated Schwannoma. The overall profile of the tumor is similar to that of a classic Schwannoma, subcutaneous well-circumscribed nodule, but when we have all these degenerative changes superimposed, it can be quite challenging with little or no Antony A or Antony B features present. In addition, degenerative changes can include cytologic atypia with large pleomorphic hyperchromatic nuclei. Typically, the saving grace with ancient or degenerative changes is that amidst the atypia, there's little to no proliferative activity or mitoses. We can see variably fibrotic and more edematous or myxoid stroma associated with irregular dilated blood vessels, thickened hyalinized walls, and at close examination, usually sparse, but clearly atypical hyperchromatic cells, but on further scrutiny, no concomitant increase in mitotic activity as would be typical of a malignant neoplasm. Granular cell tumor, also known as granular cell Schwannoma, is defined primarily by its distinctive cytologic appearance, large cells with granular cytoplasm and a relatively small nucleus. The abundant cytoplasm created by the cytoplasmic granularity is usually somewhat pale, eosinophilic. These are non-encapsulated tumors that can otherwise exhibit a variety of growth patterns, including solid, diffuse, plexiform, fascicular, often largely displacing and entrapping collagen fibers. Another aspect about granular cell tumor that is highly clinically relevant is the predilection for pseudocarcinomatous epithelial hyperplasia. So these lesions can occur anywhere, but the tongue is an especially common site. So in superficial skin biopsies, there is a risk of overcalling pseudocarcinomatous hyperplasia as a squamous cell carcinoma if one does not appreciate the granular cells at the base of the superficial biopsy. I sometimes have difficulty distinguishing granular cell tumors from xanthomas on H&E, and I found that the presence of pustulo-ovoid bodies in granular cell tumors to be the single most helpful clue to make the diagnosis of granular cell tumor. In this study by Gollitz and colleagues, the pustulo-ovoid bodies were present in all of the cases. So here are several examples, and basically, xanthomas don't do this. And in the most classic examples, the concentration of granules forming the pustulo-ovoid body is associated with a corresponding retraction or halo surrounding it. So here we have xanthoma and granular cell tumor side by side, head to head. Can you tell which is which? In your world, this is a question of salt versus microfoam. Once you've established that you do indeed have true granular cells, one still needs to distinguish the classic granular cell Schwannoma, which is S100 positive and believed to be derived from Schwann cells, from other tumors that merely exhibit cytoplasmic granularity. So even dermatofibromas, dermatofibrosarcoma protuberans, atypical fibroxanthoma, a variety of tumors, even basal cell carcinomas can have granular cytoplasm. And the malignant granular cell tumor is a very rare but real entity that also needs to be considered. Sometimes you will see overt features of malignancy, including necrosis and lymphovascular invasion, but at the other end of the spectrum, sometimes they don't look that bad microscopically. So clinical features are important to consider in determining the potential for a malignant granular cell tumor. So rapid growth, ulceration, large clinical size, or clinical recurrence are also features that should be considered. Nerve sheath mixoma is a benign tumor that usually presents as a solitary papule. It can occur anywhere, but has a predilection for the fingers. And it's histologically distinctive. It's a dermal-based tumor with loosely clustered multilobular growth pattern and myxoid stroma. The individual lobules of tumor cells can be characterized as theques or nests. And I think we can see here that the growth pattern is a little different from all of the other neural tumors that we've looked at, as well as different from the appearance of intradermal melanocytic nevi. The tumor cells are positive for S100 protein and tend to exhibit a spindled or dendritic profile, and often quite a bit more myxoid stroma than is seen in this example. Actually, the central portion of this tumor exhibits the more characteristically prominent myxoid stroma, and some people have considered the possibility that the nerve sheath myxoma is kind of an endoneurioma, if you will, proliferation of perhaps a modified Schwann cell in conjunction with endoneurial connective tissue. By the same token, though, I think we would best be advised to refrain from proposing new names or classifications for nerve sheath myxoma, as well as this one, the former nerve sheath myxoma 2, now known as neurofibroma. I think one of the nice things for millennials training in the 21st century is that you did not have to train through the period of what basically was a veritable hit parade of evolving names for what we now know as neurofibroma and the previous entity, nerve sheath myxoma. So neurofibroma, formerly known as cellular neurofibroma, and a bunch of other names listed here, is also a multilobular tumor and previously was thought to be related or on a spectrum with nerve sheath myxoma. No longer the case. These are regarded as being histologically overlapping but biologically distinct tumors. So we have the multilobular pattern with the little nests or the theques, but neurofibroma is S100 negative by definition. It can express a variety of markers, some unexpected. PGP 9.5 is the one that I typically associate with neurofibroma, as well as NKIC3, but none of these markers are specific for the diagnosis. There are also many histologic variants that we don't have time to discuss now, but the appearances of these tumors sometimes can resemble that of a Spitz melanocytic proliferation or a histiocytic proliferation. Again, we see that multilobular pattern of growth, but in contrast to nerve sheath myxoma, we do not have prominent myxoid stroma, and if there was any doubt, this tumor is S100 negative. And over a decade ago, a comprehensive analysis of a large number of neurofibromas by soft tissue pathology experts, Drs. Hornick and Fletcher, concluded that there was in fact no good evidence of nerve sheath differentiation in neurofibroma, then known as cellular neurofibroma. And more recently, Dr. Sarah Dry and colleagues at UCLA used a molecular approach to demonstrate that nerve sheath myxomas are more similar genetically to Schwannomas, whereas neurofibriomas more closely resemble dermatofibromas or cellular fibrous histiocytoma. Perineurioma is a benign tumor that may arise within a nerve, but more commonly arises extraneurally within the soft tissue, where we might see it involving the skin. There's a characteristic onion skin fibrolamellar stroma associated with nerves and vessels, and the immunophenotype is distinctive. EMA positive, like meningioma and meningothelial hamartoma, and also GLUT1 positive. GLUT1 is a infrequently used, but when it's used, it's very powerful in dermatopathology. It is positive in a very short list of rare, distinctive, and non-histologically overlapping entities. So perineurioma, infantile hemangioma, and EMH. Soft tissue perineuriomas do have a predilection for the fingers, where they tend to be associated with prominent sclerosis, that is to say, sclerosing perineurioma. This one at low magnification actually kind of resembles an onion, but this is not what is being referred to with the fibrolamellar pattern. That's something seen at higher magnification. At median magnification of this well-circumscribed but non-encapsulated tumor, we can see relatively thin collagen fibers of varying density, some areas compact, others more loose, with lots of small intervening blood vessels. Growth pattern could be characterized as storiform, but often and characteristically exhibits a bit more patterning, sometimes more of a swirled or lamellar pattern to the collagen, and areas of more concentrically arranged collagen resembling the layers of an onion, and not always necessarily surrounding a blood vessel as shown here. Spindle cells are cytologically bland. And areas with prominent sclerotic stroma in sclerosing perineurioma. Turning our attention to lipomatous tumors, let's first take a look at normal subcutaneous fat tissue. We have lobules of well-differentiated fat cells known as adipocytes or lipocytes, separated by collagenous septa. Septa is the plural, present in continuity with the overlying collagen in the deep reticular dermis. And looking at the individual adipocytes in a formalin-fixed paraffin-embedded specimen, we're basically just seeing an empty white-colored space where the lipid was washed out. And corresponding to each adipocyte is the nucleus of the adipocyte. The list of special stains for lipomatous tumors is relatively short. As is true for all of these soft tissue tumors, the vast majority of them can be diagnosed without special stains, but S100 would be the basic highly sensitive stain for adipocytes. We can see here, and this is telling actually because I just pulled our S100 control tissue and it does not even include proper subcutis. Here I'm looking at the deep dermis where we have eccrine glands that have some scattered positive cells, but what we have are just kind of periappendigeal adipocytes, but you can see them nicely highlighted and forming their typical signet ring appearance on S100 protein stain. And perhaps you will be relieved at this juncture to know that after looking at about a baker's dozen worth of neural tumors, I'm going to show you half the number of lipomatous tumors. But once again, quick reality check. If you want the full list, it looks more like this. Nevus lipomatosis is typically congenital or of childhood onset and presents as a small group or cluster of large, soft, polypoid skin tag-like lesions on the hip or upper thigh. And microscopically, there's markedly increased well-differentiated fat in the papillary and upper reticular dermis, not typically in continuity with the underlying subcutis. Now, I suspect that nevus lipomatosis is probably one of the more common overdiagnoses that dermatopathologists are guilty of, and the reason is that there's a lot of histologic overlap with the large fatty skin tag. Okay, we sometimes put them in our pathology reports as acrocordon or fibroepithelial polyp to sound a little more sophisticated, but these are all names for skin tags, which are incredibly common and often incredibly annoying to patients. They want to have them removed. So large skin tags often have a fatty core, and we can't really reliably distinguish large fatty skin tags from nevus lipomatosis. So I think many times, and I know that I've been guilty of this in the past, is that I'll see something like this and I'll just call it nevus lipomatosis, but I either don't have access or I don't check the history, and typically this is going to be a solitary lesion in an adult, and the patient probably has not had this for their entire life, so it's much more likely a skin tag, but a lot of times these just get called nevus lipomatosis anyway, and to no great harm to patients in aggregate, so that's a good thing. Almost as incredibly common and comparably annoying to the skin tag is the lipoma. This image on the lower right was the largest lipoma that I personally removed in my past life as a dermatologic surgeon, but now as a pathologist, I see these multiple times a day, and lipomas are characterized by lobules of well-differentiated fat, typically centered in the subcutis, although they can sometimes be deeper or more superficial, and the individual tumor cells look like fully differentiated adipocytes. So on one hand, clinicians are generally submitting these knowing the clinical diagnosis, and it's just confirmatory, and because they can't throw out the tissue and to make sure it's not something rare and unexpected. But at the same time, the appearance in partial samplings of lipomas may be indistinguishable from regular physiologic subcutaneous fat lobules. So it is important to accomplish that clinical pathologic correlation and make sure the clinical setting is compatible with a lipoma or lipoma versus cyst, and that you're not just readily calling subcutaneous fat a part of a lipoma when it doesn't fit the clinical. Angiolipoma can be clinically indistinguishable from conventional lipomas, although they do have a predilection for the extremities and are more likely to be tender. Microscopically, we see lobules of well-differentiated fat, just like regular lipomas, but there's variable degrees of vascularity, small, thin-walled blood vessels. In addition, we also like to see, and in fact do expect, the presence of small fibrin thrombi within these small blood vessels. Regarding the pathogenesis of angiolipoma, investigators from Friedrichshafen and Madrid have demonstrated a recurrent activating mutation in PIK3CA in over 75% of their series of both conventional and cellular angiolipomas, thereby supporting a role for PIK3CA mutations in these tumors, and also placing angiolipoma within the broader spectrum of PIK3CA related overgrowth spectrum or overgrowth syndromes that can involve both malformations and benign proliferations of vessels, lymphatics, and also fatty tissue. And it does kind of make intuitive sense to me that the extent of fibrin thrombi within an angiolipoma would correspond with the degree of pain and tenderness clinically, but whatever the reason, angiolipomas do have a reputation for being one of the painful skin tumors. And for the dermatology residents in particular, you probably already know this acronym. Tumors that are very histologically distinctive but also benign for patients are a win-win, and that is what we get with spindle cell pleomorphic lipoma. In the classic setting, it arises on the upper back, neck, or shoulder area of an adult man. And in fact, when I was a resident way back when, I was told that if the tumor was not arising in this clinical setting, one should actually question the diagnosis. Nowadays, it's quite a bit more gender equal. So the entity is well recognized to occur in women as well as men, and also other variants. So examples involving the extremities and even confined to the dermis have been reported. There are a couple of buzzwords, at least in America. I'm not so sure that this is as true in Europe, but at least in America, among dermatopathologists, there's a couple buzzwords for this diagnosis. So school of fish, pattern of growth of the spindle cells, and associated thick, ropey, or wiry collagen. So I'll try to show some examples of that, but the collagen fibers kind of stand out from amidst the spindle cell proliferation, and they're probably larger and more birefringent. In addition, the immunophenotype is distinctive, so CD34 positive, but in contrast to normal adipocytes, S100 negative, and more recently, the tumors have been shown to be deficient in retinoblastoma protein expression. To make matters even more interesting, the degree of fat versus spindle cell, or the fat-spindle cell ratio, can vary quite a bit from tumor to tumor and even from one portion of a tumor to another, so that one gets so-called low-fat and even fat-free variants of spindle cell pleomorphic lipoma. Historically, also, these two entities were separated, but more recently they've been lumped together in recognition of their overlapping histologic as well as molecular features. So in spindle cell lipoma, we have bland monomorphous spindle cells set within a variably myxoid stroma, and we can see that the spindle cells are somewhat organized or aligned in kind of a swirling or whorled pattern that can resemble the pattern seen with a school of fish. And amidst the small spindle cells and myxoid stroma, there are scattered inordinately thick or ropey collagen fibers. So again, pleomorphic lipoma is now on a histologic and pathogenetic spectrum with spindle cell lipoma, but it does have its own distinctive features consistent with its original classification as a separate entity. So pleomorphic lipoma is characterized by pleomorphic cells, in particular a somewhat bizarre multinucleated cell known as the floret cell. It has somewhat of a wreath-like arrangement of nuclei, kind of resembling the petals of a flower. And I didn't have a good tissue section of pleomorphic lipoma, so this is a case that is courtesy of Dr. Ed Uthman from Texas via his Creative Commons postings on Flickr. So thank you, Dr. Uthman, for letting me use your excellent case of pleomorphic lipoma, and I see some other multinucleated cells that I think would classify as floret cells, as well as some not clearly multinucleated, but atypical pleomorphic cells. Histologically distinctive tumors, even if they're very rare, tend to make good test questions. So seasoned residents, please pause and diagnose. Hibernoma is a benign lipomatous tumor composed of brown fat, resembling the mitochondria-rich brown fat of hibernating animals. Physiologically, in humans, it's the newborns and children that tend to have the most brown fat, and it can persist in certain locations, such as the axilla or mediastinum. But as an acquired tumor, hibernoma occurs in a different distribution. It's usually a solitary lesion in adults, and it tends to be located more on the trunk or proximal extremities. That is to say, sites where brown fat normally does not exist. There are varying appearances depending on the degree of differentiation. So the more immature cells will have granular cytoplasm and a more centrally situated nucleus. Eventually they become more multivacculated and finally univacculated with a peripheral nucleus like a mature adipocyte of white fat. Turning our attention now to lipomatous tumors with at least some metastatic potential, we have well-differentiated liposarcoma. However, well-differentiated liposarcoma has more recently been classified as atypical lipomatous tumor in recognition of the fact that unless there's some sort of malignant transformation or dedifferentiation, it essentially has no metastatic potential. However, it still can cause problems where it arises because these are not primary skin tumors as a rule. These arise in soft tissue or the retroperitoneum. The classic cell in liposarcoma is an immature adipocyte known as a lipoplast. In addition to cytologic atypia, there tend to be multiple vacuoles in the cytoplasm that cause indentation or scalloping of the nucleus, kind of like what we see in sebocytes in skin adnexal tumors. So liposarcoma can be classified into well-differentiated and undifferentiated variants, and the ones that are more common are the well-differentiated liposarcoma's atypical lipomatous tumor, and they can have various histologic patterns, some resembling a lipoma, others more sclerosing or inflammatory. On the other hand, undifferentiated liposarcoma is more of a different animal. These are more likely to arise even deeper in the retroperitoneum, for example, and have other distinctive histologic appearances as listed. All liposarcomas have numerous distinctive markers, so in addition to S100, typically these are positive for P16, CD10, CDK4, and MDM2. And at high magnification, we can appreciate overt cytologic atypia and distinctive lipoblast morphology with the multiple vacuoles causing indentation of the atypical nucleus. There also looks like there's some pseudonuclear inclusions here as well. And so, as we get closer to the end, I propose that we make the list of disorders even shorter. So we can have a short list, and that's partly facilitated by the fact that in the broad superficial world of dermatopathology, we can largely get away with skipping skeletal muscle and certainly cardiac muscle tumors, but we do need to deal full on with a wide spectrum of smooth muscle related tumors. And so this is front and center for the differential of spindle cell tumors. And there are some overlapping features with nerves, but there are also multiple features that we can use on H&E to make the distinction in the vast majority of cases. So smooth muscle cells are spindle cells. Their nuclei do have more blunt or blunt-ended or cigar-shaped nuclei in contrast to the wavy and tapered or S-shaped nuclei of nerves. In addition, smooth muscle cells have more abundant eosinophilic cytoplasm compared to the relatively smaller Schwann cells and neurons. In addition, smooth muscle cells often have intercytoplasmic vacuoles that are often characteristically located perinuclear. So this would be probably the first one that I'm seeing right here, these empty vacuoles right at the tip of a longitudinally sectioned spindle cell nucleus. Here's some that are a little bit more off-center, and sometimes they're just sitting right there, not clearly associated with the nucleus. But these vacuoles are typical of smooth muscle. We have a relatively short list of immunohistochemical stains that can be used to assess myoid differentiation. But like with the other soft tissue tumors, these special stains are not needed in the majority of cases. The smooth muscle actin SMA is the one that's probably ordered by far and away the most, but I probably still order that no more than weekly to monthly. And once again, a reality check against Rakena and Kutzner's classification in cutaneous soft tissue tumors will show that we're really just scratching the surface of tumors with myofibroblastic and muscle differentiation. Myofibroblastic we're not even going to touch now. That often is included under the fibrohistiocytic topic. But looking at the other categories, we can really get away with just a very small number of lesions in terms of what would typically be routinely encountered perhaps on at least a yearly basis in most dermatopathology practices. Starting with smooth muscle hamartoma, obviously a benign lesion that does have a variety of clinical subsets, but for the pathologist, they all look the same histologically. One interesting clinical feature is the pseudo-Derrier sign, where rubbing the lesion may cause some elevation and induration that mimics the urtication of cutaneous mastocytosis. Histologically, we see an increased number of bundles or fascicles of well-differentiated smooth muscle fibers that look essentially identical to the muscle of hair erection, the erector pili muscle associated with hair follicles centered in the mid-dermis. And there can be variable epidermal and epithelial changes with hyperplasia, hyperpigmentation, and increased hair growth in cases associated with Becker's nevus. Smooth muscle hamartoma can occur on the trunk, where it can also bear some histologic resemblance with normal areolar tissue. Both entities are characterized by increased numbers of fully differentiated smooth muscle fibers in the dermis. However, only normal areolar tissue is associated with mammary ducts and glands. So you have to be somewhat lucky to have a nice section of the actual mammary duct and gland. So I don't have that here, but even if you're off-center, you'll still see the associated modified apocrine glands of the mammary tissue that you would not see in a smooth muscle hamartoma. Benign neoplasms of smooth muscle are designated leiomyoma, and in the skin there are essentially two major variants. So the pilar type, or piloleiomyoma, is centered in the mid-dermis, small bundles that essentially are recapitulating erector pili muscle. The external genitalia leiomyomas are distinctive, but we're skipping over those for now. The other distinctive type is the vascular or angioleiomyoma. This is present deep in the reticular dermis or superficial subcutis, and it recapitulates vascular smooth muscle. And for those who are into the genetics, pilar leiomyomas, multiple, are associated with hereditary leiomyomatosis with renal cell carcinoma, Reed syndrome associated with the fumarate hydratase mutation. And for vascular type leiomyomas, there's a variant called cutaneous angiomyolipoma, which in contrast to the renal angiomyolipoma is not associated with tuberous sclerosis. In this example of piloleiomyoma, we see the histologic images of the clinical lesion depicted here from my old resident collection, and it has some overlap with the appearance of smooth muscle hamartoma, but in contrast to smooth muscle hamartoma with its discrete, well-differentiated smooth muscle fascicles, here the growth pattern is more solid and nodular, that of a tumor. One more example of piloleiomyoma. This patient had multiple papules, and biopsy of one of these showed more of a tumor pattern of proliferation, solid aggregates of spindle cell fascicles. And we can identify them as smooth muscle at higher magnification. With fascicles that are sectioned more or less longitudinally, we can appreciate the spindle cell shape of the nuclei, and we can see the intracytoplasmic vacuoles, some of which are situated at or near the tips of the spindled nuclei. And when we happen to see the fascicles cut in cross-section, the spindle cells are kind of coming right at you, so you can't really appreciate the spindled shape. They're more circular, but you could still see the abundant eosinophilic cytoplasm and numerous intracytoplasmic vacuoles. So both smooth muscle hamartoma and piloleiomyoma are composed of bland smooth muscle fascicles, but with smooth muscle hamartoma, it's more of a sparse, discrete pattern of growth, whereas with piloleiomyoma, we have solid aggregates of compact fascicles, more typical of a neoplasm. Angioleiomyoma is a much deeper, circumscribed, often shelled-out tumor nodule, and sometimes it'll appear that a precursor muscular walled vessel is present. Leiomyosarcoma designates the malignant counterpart of leiomyoma, and cutaneous leiomyosarcoma has some distinctive features. Microscopically, you would expect the usual features of malignancy, so irregular infiltrative growth with atypia and mitoses, but the prognosis in cutaneous leiomyosarcoma depends critically on the location. So the smaller superficial lesions that are limited to the dermis, even cytologically and immunophenotypically identical to the bigger, deeper, nastier ones, exhibit essentially benign behavior after complete excision, so much so that some have proposed that they not even be called sarcomas. Rather, the term atypical intradermal smooth muscle neoplasm has been proposed. However, once the tumor extends down into subcutis, or if it's arising from or within subcutis or soft tissue, then the prognosis is correspondingly worse. And of course, leiomyosarcoma has potential for distant metastasis, the worst of all. In leiomyosarcoma, we have very compact, irregular fascicles of atypical spindle cells, a little bit more of an infiltrative pattern of growth in many areas, such as the periphery of the tumor here. And even from medium magnification, I can make out these large basophilic aggregates, some or all of which surely correspond to large atypical nuclei and or mitoses. And at high magnification, we have confirmation of cytologic atypia with large hyperchromatic spindle nuclei, occasional mitoses, and highlighted in green, intracytoplasmic vacuoles as histomorphologic evidence of smooth muscle differentiation. Having said that, though, I think that at least for me, these are rare enough in practice that I would get confirmatory immunostains. Probably smooth muscle actin and desmin would typically suffice in most cases. Okay, so we've been at this for a little over 15 minutes, so if you're getting tired, I've covered all of the topics that I promised in the title, so you can go ahead and just stop watching now. However, you may have noticed in the title slide that the official pathology hashtag ontology for bone and soft tissue pathology is hashtag BST, so that's bone. And we don't really see bony tumors in the skin to speak of. I mean, they certainly do exist, but they're all pretty exotically rare. But there are a couple of entities that we do see a little bit more commonly. I don't have anywhere else to squeeze them into our curriculum, so I'm going to talk about them here. You can always just come back later. Just know that they're here for future reference. So osteoma cutis is actually relatively commonly seen, often as an incidental finding in large excision specimens. But the clinical setting in which it's encountered most often is miliary osteomas of the face, such as shown here, multiple little hard papules. Now there is a whole differential for osteoma cutis, just like there is for calcinosis cutis and other depositions. Won't go into those now, except for the last one, subungual exostosis. Typically we'll see spicules of bone situated in the dermis, compact eosinophilic bone with small osteocyte nuclei. And in the center here we have my version of a classic pathology food analogy. Sometimes the fatty vascular marrow space will in fact be recapitulated in the center of osteoma cutis. Another feature that I find is not always recognized in textbooks, at least, but I see it quite commonly in practice, is that the central portion of the osteoma cutis will actually be basophilic or calcified. And finally, we have subungual exostosis, with which many equate with the term subungual osteochondroma. However, like osteoma cutis, the exostosis is a tumor only in the clinical sense, not a pathologic or neoplastic sense. These stereotypically occur on the medial aspect of dorsal distal big toe and may alternatively be regarded as a cartilaginous tumor, as it represents a form of localized enchondral bone formation in response to external trauma. In practice, probably the biggest clue to the diagnosis is simply the presence of eosinophilic compact bone in the superficial dermis on acral skin in the classic location. Associated calcification and cartilage may not be seen in a superficial sample. Okay, I'm finished. Thanks for your attention. If you'd like to hear more like this, please check out the rest of our curriculum, which starts again in July with our new dermatology and pathology residents.